Assalamu alaikum. Assalamu alaikum. Good evening. I'm Hajja. I'm a third year medical student. Inshallah, اليوم we're gonna do MSK review questions. But before we start, guys, can you how are you? How are you doing? How is MSK so far?
Pretty good, wallah.
Sorry?
It's
Alhamdulillah.
good, alhamdulillah.
Are you guys ready? Because the exam is on Sunday. I hope, inshallah. Okay, so guys, before we start, I know this period was so hectic, but you're coming to the last exam of this period, which is the MSK. You have to push through a little bit. It's only just 2 days left. It's on Sunday, then you will stop doing exams till the end of the semester. So inshallah, you all got this. Before we start, I just want to tell you something about MSK. To be honest, MSK was one of my favorite blocks in first year, and I actually did the best. One of my best blocks I did in the exam. So hopefully, inshallah, you all do the same. But the SAQ thing was I messed up in the SAQ. It's not because of the exam, because I didn't read the question. So just make sure to read all of the questions from the first letter till the end, just to understand everything, okay? So talking about this session is going to be like MCQ questions. I tried my best to ask my colleagues from my batch, from the 14th batch, and I also asked some of my friends in your batch, guys, what exactly the doctors focused on, what did they try to address during the lecture, what's the most important thing. I also went over the previous exams, some of the lectures, some of the high yield points. Inshallah, I included most of the things that are important, especially for the lower limb. I highly advise you to go through the questions. Make sure to understand the concepts, because if you don't, you won't get the same exact question, but you will get something similar. I'm pretty sure you get something similar, okay? The way this session is going to be, I'll put the question like 80 seconds, then we can answer it, okay? If you want, I can answer it. If you want to unmute yourself, you can answer it. Just raise your hand or unmute yourself and answer it, or just type in the chat, whatever suits you guys. Then we're gonna have like a brief explanation about the question. Then we're gonna move on to the other questions. I included only anatomy, some of the upper limb, and most of it is going to be the lower limb, okay? Because you guys were not tested on, so I assume it's the hardest thing. And yeah, let's get started. Are you guys ready? By the way, some questions are kind of hard, but some of them are easy, okay? So I put everything because in the exam you will find questions that are hard, and also you'll find some questions that are easy, okay? Is my voice clear? Okay, I talked a lot. I think I should start. Okay.
Yeah, it is clear.
Okay, so let's get started. This is the first question. Okay, so guys, I put 80 seconds. I'll read the question, try to answer it, then we will answer it together, okay? The right shoulder of 78-year-old female had become increasingly painful over the past year. Abduction of the right arm caused her to wince from the discomfort. Palpation of the deltoid muscle by the physician reduced echoes of pain. Imaging studies reveal intramuscular inflammation extending over the head of the humerus. What structure was inflamed? So guys, take your time. We're having 80 seconds for each question, so take your time. Okay. Anyone wants to answer the question?
They are saying D in the chat.
It's D.
D. Okay. Anyone wants to explain, or do I go ahead?
It's a subacromial bursa because it is in the subacromial, which is where the deltoid is located.
Mm-hmm.
And the attachment for the deltoid, the distal attachment is the deltoid tuberosity, but the acromion is one of the attachments for the deltoid, the
Okay.
proximal.
Yes. So guys, the answer is D. Why is the answer D? Let's start from the beginning of the question. Okay, 78-year-old. Abduction of the right arm caused her discomfort. Okay, so we have discomfort upon abduction. Now, palpation of the deltoid muscle also produced pain. Imaging studies revealed inflammation extending over the head of the humerus. So now we have three main things: that we have pain upon abduction and we have inflammation over the head of the humerus. Okay, now let's start eliminating the other options. And why would we choose D? Let's start with the subscapular bursa. It could be a structure that's inflamed and causing pain, but would it cause the pain upon abduction, or basically a pain upon the deltoid region? It's obviously not, because it's kind of located slightly away. We're going to see a picture that's explaining this, so we can cross it by now. Infraspinatus muscle. Infraspinatus is not responsible for the abduction. So it's responsible for lateral rotation, as well as it's responsible for lateral rotation. So that's why we can also eliminate it, okay? Now it comes to the glenohumeral joint. It could be a possible answer, and D, it could be a possible answer. E, it won't, because it's not associated with abduction as well. So we can cross it out, okay? Now we can go back to the question to see where's the inflammation actually. It's located over the head of the humerus, okay? So what's exactly going to be located over the head of the humerus? It's going to be the subacromial bursa. Now, what is this called? It's called subacromial bursitis, okay? Now, as we can see here we have this area is called the coracoacromial arch, okay? It's basically extending from the coracoid process all the way into the acromion. What are the important structures that are located within this area? The first one is going to be the subacromial bursa, okay? Underneath the subacromial bursa, we have this tendon of the supraspinatus muscle. It's kind of over here, okay? So now when we have an inflammation of the subacromial bursa, sometimes there could be swelling, there could be some inflammation. This would also cause like a damage to the supraspinatus tendon muscle. It would cause something like impingement or whatever, okay? This would result in syndrome, especially in the elderlies. It is called the painful arch syndrome, okay? It's happening mainly because of the subacromial bursitis, which is seen in this situation. So the subacromial bursa, it's like of compressing the supraspinatus tendon, which would result in pain upon abduction, okay? And you can see here that the subscapular bursa is located kind of far away from the area of the head of the humerus. That's why we eliminated this option from the answers, okay? One more important thing I want you guys to know is that in the slide, Dr. Ataf put an injection-like thing. So the most common site of injections in the deltoid region could be the subacromial bursa as well as the subdeltoid bursa. But because the subdeltoid bursa is easily accessible, as you can see from this side, on the other hand, the subacromial bursa is not easily accessible because of the ligaments. That's why injection most likely is going to be at this area, okay? Anyone has any question, or do we move on to the second question? Okay, so
You are saying clear.
okay, clear. Let's move on to the second question. Okay. Yeah, 1 minute. MashaAllah, guys, you're all answering the chat. خلاص, no need to get the session. MashaAllah. Okay, I think that it doesn't necessarily need one minute, so I'll start, okay? So a 34-year-old female skier was taken by ambulance to the hospital after she struck a tree on the ski slope. Imaging gives evidence of shoulder separation. Khalas. That's the keyword. We all know now what's the question is going to ask about. Okay, which of the following typically occurs in this kind of injury? Now, before reading the answers, let's talk about shoulder separation. The reason I brought this question is that I want you guys to differentiate between shoulder separation and shoulder dislocation, okay? Shoulder dislocation was mentioned in the shoulder region. I saw you guys that you guys don't need any questions on it, so that's why I didn't put any question about the dislocation. However, it's an important topic, so review it because you might get questions about it in the final exam, okay? I wanted to bring a question about shoulder separation because it's associated with some important ligaments. Now, what are the ligaments? Here, as we see, in shoulder separation, we have the disruption of the acromioclavicular joint, okay? So this is the acromioclavicular joint, that's over here. So it's acromioclavicular, acromio and clavicular. It's going to be disrupted, okay? Which is resulting in the shoulder separation. Now, we have to know the two ligaments that are associated with a damage or a separation of the acromioclavicular joint. The first one is going to be the acromioclavicular ligament, obviously, because it's the ligament of this joint. So it could be damaged. The other one is going to be the coracoclavicular ligament, which is also seen in this one. Okay. Now let's go back to the question. Displacement of the head of the humerus from the glenoid cavity. I told you I want you guys to differentiate between shoulder separation and dislocation. So we can eliminate this. Partial or complete tearing of the coracoacromial ligament. As we said, it's not kind of involved. So that's why basically sometimes in the MSK, you will find ligaments that are more involved than other ligaments, maybe because they are stronger, their close relationship with the site of the injury. So it's not mentioned that it's related to the shoulder separation, so that's why we can cross it out. Rupture of the transverse scapular ligament. Actually, I don't know where it's dislocated, so but it says scapular, so it's far away than the area of the acromioclavicular joint, so we can eliminate it. Disruption of the glenoid labrum. It could be a possible answer. However, they specified shoulder separation, and we all know from this image is that the most common ligaments are the coracoclavicular ligament as well as acromioclavicular ligament. So that's why the answer is going to be B. Okay. What else they can bring question on from this shoulder separation is that sometimes if the injury is extensive, what's going to happen is that there will be a fracture of the clavicle. Okay. So sometimes there could be a fracture of the middle third of the clavicle. Now, I have a question for you. If there is a fracture of the clavicle, this end is going to move, and this end specifically is going to move upwards. Guys, can you please tell me why exactly this end of the clavicle is going to be pulled upwards, sorry? Just someone answers it.
Because of sternocleidomastoid muscles.
Sternocleidomastoid.
Exactly. So this is an important thing to note also. Dr. Atifs like to ask about these questions. For example, if we have a separation, dislocation, fracture, the fragments are going to move somewhere. What exactly causing these to move somewhere else is basically the attachment of the muscles. Okay, so in case of the clavicle, we have the sternocleidomastoid, which is a muscle of the neck that's attached to this end of the clavicle. If it's fractured, it will pull the clavicle upwards. Same situation could happen in shoulder dislocation. If we have a shoulder dislocation, as we all know, most common side is the inferior dislocation. Okay, but when it dislocates inferiorly, it's going to be displaced into the anterior side. Why would it be displaced into the anterior side? Because of the attachment of the pectoralis major muscle. Okay, this is another situation, and we're going to see some of them in the lower limb as well. Okay, I just want you to know this concept. So as we said, it's basically shoulder separation. Now, important thing to note down is that these types of injuries, the rugby football, the ice hockey, and the riding accidents, okay? Because sometimes in the question, the doctor puts these as keywords, and if you know it, it's gonna make the question easier, trust me. It's just from its name, rugby football. What's gonna happen sometimes, or ice hockey, people are going to smash against each other, which would cause like a damage to the shoulder. Okay, it's not a straight indicator, but it could help you. Okay. Any questions? Okay, I think it's clear. Okay, clear.
Amr, someone's asking about, are you going to solve physiology questions?
Actually, I was not able to put physiology questions as well because I noticed that the anatomy questions were a lot, and there were a lot of important concepts. So that's why I just focused on anatomy. Okay. But I can tell you what resources you can use for physiology if you want to practice some questions along. Okay. And also one thing, because the important physiology lectures and the complicated ones were given by good PAL tutors, which inshallah is going to help you in the exam. Let's move on to question 3. I think it needs just 30 seconds because most probably you're going to know the answer immediately. So go ahead.
The upper trunk.
Yes, exactly.
Or to be more precise, stanchi palsy.
Yes, exactly. You're right. Okay. Time is up. So, anyone wants to answer the question, by the way, or do I go ahead and answer it? Okay.
It's the upper trunk.
Okay. Can you explain why? Would you like to explain why?
Because when it's the Duchenne's palsy,
Mhm.
because we have a stretch, the angle between the shoulder and the neck has been stretched, so it causes an injury to C5 and C6, and it will give us the Duchenne palsy thingy. Exactly.
Yes, you're right. So it's actually the upper trunk. This is as you guys said, it's Duchenne palsy. Now, you guys, I think your expertise with these questions, because you should have mastered the brachial plexus from the midterm, and inshallah you won't face any difficulty. But I thought it's important to just go over it again, just to review it for the final exam once again. Okay, so let's read the question. Basically, the first part of the question, the most important thing is going to be a newborn. It could be an indicator, but just highlight it just in case. Then physical examination shows her left arm to be adducted, internally rotated, forearm extended, pronated, and the rest is flexed. Okay, so now we have to know why are these things happening, because sometimes, for example, in the SAQ, they will tell you, okay, there's adduction, there's internal rotation, there is all of these things. Now, explain why are these happening. Okay, so you have to say, for example, which muscle is damaged and so on. So now let's go over the brachial plexus just in brief. As we said, it's Duchenne palsy, so it's targeting the upper trunk. Okay, so here we have C5 and C6 are damaged in this area, which is basically the upper trunk. Now, if we have this that's damaged, everything along it is going to be damaged as well. Let's start with the first one that's going to be damaged. That's basically the suprascapular nerve. Now, if we have a damage to the suprascapular nerve, I'm going to ask quick questions and answers, okay? Suprascapular nerve is damaged. Which muscles are going to be affected?
Infraspinatus and supraspinatus.
Okay. Supraspinatus is affected. What's the function of supraspinatus?
Initiation of abduction.
Okay. Infraspinatus?
Medial rotation.
Infraspinatus?
Lateral rotation.
Lateral rotation.
Exactly.
Okay.
Why it's lateral rotation? Because actually I don't have a picture, but if you see its attachment, it's actually attached in the outer part of the humerus. So what's going to happen is that when it contracts, it's going to kind of laterally rotate the arm. Okay, just look at the attachment and you will understand what I mean exactly. But the important thing here is that suprascapular nerve is damaged. So supraspinatus and infraspinatus. Supraspinatus is not the major one for abduction, so let's keep it on the side. We have infraspinatus. Infraspinatus responsible for lateral rotation. Lateral rotation is not there because it's affected. What's going to happen? The opposite function, which is medial rotation. So this is the first one of the symptoms, medial rotation. Why is it happening? Damage to the suprascapular nerve, damaging the infraspinatus muscle. Okay, let's move on to the continuation of the the upper trunk. We have the axillary nerve over there. Actually, I don't know why they put it here. They're supposed to put it here, but anyways, the axillary nerve. Okay, the axillary nerve is affected. Now, which muscles are supplied by the axillary nerve?
Deltoid.
Teres minor and deltoid.
Teres minor and deltoid. Exactly. Deltoid is the major abductor muscle. So no abduction. What's going to happen? Adduction. This is the second symptom. Okay. So now we have medially rotated, adducted. Tamam? Tamam. Let's move on to continue till to the end. We have the musculocutaneous nerve. Now, can you please tell me what are the muscles supplied by the musculocutaneous nerve?
Flexors.
Brachialis, coracobrachialis, and biceps brachii.
Okay, exactly. So we have the biceps brachii is affected. The major function of the biceps brachii is
Supination.
Supination.
yeah, it is a flexor. It's responsible for flexion at the elbow. However, it's the main supinator. Okay, so supination is not there. What's gonna happen? Pronation. So medial rotation, adduction, pronation. Okay. Now let's talk about the other muscle that's supplied by the musculocutaneous nerve, which is the brachialis. Brachialis is the major flexor of the elbow joint. Okay. Now flexion is not there, so what's going to happen? It's going to be extended, which is the fourth symptom. So medial rotated, adducted, extended, and pronated. Yeah, we have one that's missing. The other one, it's basically when the wrist is flexed. Which nerve is responsible for the extension of the wrist?
Radial.
Radial nerve, exactly. So here, sometimes the radial nerve could be affected, which would result in no extension. That's why it's going to be flexed. So this is basically brings us to this policy, which is called waiter's step hand or herb the chain policy. Arm is going to be medially rotated, elbow is going to be extended, forearm pronated, the rest is flexed. Okay, and adducted. Now, what things that we have to know about this? What are the types of injury that could cause herb the chain palsy? The first one is going to be when someone is thrown off from the horse or the motorcycle and landed on the sides of the neck. So there could be sometimes like a stretch of the neck, which would result in the upper trunk damage. In the case of this question, because it's a newborn, so the doctor while vaginal delivery, the doctor basically held the head of the baby and kind of stretched it, so it caused damage to the upper trunk. Okay, these are three most common scenarios where you can get herb the chain palsy. Any questions?
All clear, thank you.
Okay, let's move on. As she fell from the uneven parallel bars, the 17-year-old female gymnast grasped the lower bar briefly with one hand, but then fell painfully to the floor. An MRI reveals an injury to the medial cord of the brachial plexus. Which of the following spinal nerve levels would most likely be affected? I think it's also straight. It's an easy question, kind of.
They are saying D.
Okay. Anyone would like to explain?
I would. It's because the medial cord the medial cord is basically from A to T. It's the four branches of the brachial plexus. It's also where the ulnar nerve is.
Okay, exactly. So because they said the medial cord, so we can immediately cross out C5, A and B. However, sometimes C7 could be affected, but not always. So it's kind of, if you see it in the question, just don't focus on C7 that much. Just focus on C8 and T1, okay? So the answer here is C8 and T1. This is basically happening due to a damage to the medial cord of the brachial plexus. What it would result in? It would result in Klumpke's palsy and Horner syndrome, okay? Now let's briefly explain what's happening here. Let's go back to our brachial plexus. Here we have the C8 and T1 are affected at the medial cord. So most commonly at the medial cord. What's along the medial cord? We have the ulnar nerve, okay? So now ulnar nerve is damaged. We know that the ulnar nerve is the major supply of the muscles of the hand, okay? I'm not going to talk about the muscles of the hand now. They're coming on the way in other questions, but just briefly to know why exactly this is happening in our question. So guys, just focus with me, and if you want me to repeat, tell me, okay? So the ulnar nerve is responsible to supply the lumbricals, which they are muscles that are found in the hand, okay? Exactly the third and the fourth lumbrical. Okay. So what are now the functions of the lumbricals? The lumbricals muscles of the third and fourth finger are supplied by the ulnar nerve, and they're going to result in flexion of the metacarpopharyngeal joint. Okay. So flexion of the metacarpopharyngeal joint. Okay. Then what do? Is that they also result in the extension of the interpharyngeal joints. So they're going to be extension. So these are basically the major functions of the lumbricals. Okay. Now let's say that the ulnar nerve is damaged. We said that it's responsible for flexion at the metacarpopharyngeal. Okay. Now if flexion is lost, what's going to happen? Extension. So it's going to be extended. As we can see here, the metacarpopharyngeal joint is extended. Okay. Now it's also responsible for the extension of the interphalangeal joints. So extension is lost. It's going to result in flexion. Okay. Why these two fingers specifically? Because the lumbricals of these two fingers, which they are lumbricals 3 and 4, are the ones that are supplied by the ulnar nerve. Okay. That's why it results in claw hand, or you can call it the Klumpke's palsy or paralysis. Okay. This is in regards with regards of the hand. Now, another symptoms which they could be present in a question, and we had them in our MSK, either the final or the midterm, I don't remember exactly, which they are the symptoms of the Horner syndrome. Actually, guys, Horner syndrome is the thing that you will be getting in each block. Trust me, in each block you will see it. Even we got it in our CVP block in 3rd year. And the doctor was shocked, asking us why you guys know Horner syndrome and we still didn't get it. It's actually because of MSK, because we got it a lot in MSK and we had to know it from MSK. So guys, please know it from now, even though it's going to be more clear in the upcoming blocks. However, just know what's happening exactly from now. Okay. Now, because T1 is involved in the injury of the Klumpke's palsy, T1 actually is the nerve that carries the sympathetic supply to the sympathetic supply to different glands, muscles, and so on. Okay, but what would it cause in Horner syndrome is that T1 is damaged, sympathetic supply is lost. Okay, let's go step by step. Sympathetic supply is lost. Sympathetic is responsible for fight and flight response, right? Okay, so imagine that we're in a situation that we need like flight and fight situation. We need the sympathetic supply. Let's say, for example, our eyelid. Do we want our eyelid to be closed or opened? Obviously open to see better. Okay. So now Horner syndrome is there. Sympathetic is damaged. So the eyelid is going to be kind of closed, like a half of it. So it's going to result in ptosis. Okay. Which is basically ptosis. Okay. This is the first symptom. The other symptom is meiosis. Okay, what's happening in meiosis is that normally the sympathetic supply is going to dilate the pupil because we need our pupils to be dilated for us to see for a longer area. Okay, so if the sympathetic supply is not there, our pupils are not going to be dilated. They will be constricted, which is basically called meiosis. Okay, now we have ptosis, meiosis, and anhidrosis. Okay, anhidrosis is basically the loss of sweating. Now, during flight response, sympathetic supply, normally there would be sweating, but in case of Horner syndrome, which is basically due to damage to T1, there will be basically loss of sweat. Okay, okay. The last thing in clump case palsy I want you guys to know is that when does it happen? Usually it happens when a patient, or sorry, when someone grabs something like from upper. For example, it grabs the branch of the tree, or in this case, in the case of the question, basically what did they do is that it was the patient was a gymnast, and she grasped the lower bar. So she grasped it like this, which would result in the damage to the medial cord of the brachial plexus. Okay, this is the first situation. The second situation could happen during delivery, which is when the doctor is going to pull the baby's arm. This would result in stretch and would damage the C8 and T1. So we have two main situations. The first one is grabbing something superiorly. The second one is going to be when the doctor is going to stretch the arm. Okay? We're done with clump case palsy. Okay. I think there's a question. So can you explain the part about the claw hand again? It lagged for me. Okay, sure. So what's happening in the claw hand or the clump case palsy is that we have the ulnar nerve that's affected. Ulnar nerve normally supplies muscles of the hand. Two important muscles that are supplied by the ulnar nerve are going to be the lumbricals. Okay, which ones exactly? They are the third and the fourth lumbrical. Okay, so they are basically for these two fingers, third and fourth. No, wait, actually, yeah, exclude the thumb. Okay, exclude the thumb. So the lumbricals of the third and the fourth. So what's the normal function of the lumbricals muscle is flexion at the metacarpopharyngeal joint, which is this joint. Okay, this one that's here, metacarpopharyngeal joint. So flexion is not there. What's going to happen is that there will be extension. Okay, as we can see here, it's extended. Now it's also normally responsible for extension of the interpharyngeal joints, these and these. Okay, these are going to be lost because of the damage, which would result in the opposing function, which is going to be the flexion. Okay, that's why we can see extension here and flexion here, and they are normally happening in this finger and this finger because of the ulnar nerve only. Okay, is it clear? Any questions?
All clear.
Okay. So because someone asked in the chat, I hope you get it by now. Okay. So I'll move on to the second question. If you have any question about anything earlier, just let me know. Okay. Let's go. Guys, before you see the question and read the question, this question is kind of hard. So please focus while answering it. I know it's kind of hard, but this is a concept that you need to know. Okay. So go ahead.
Some of them are saying E on the chat.
Okay.
Some Ds and some Ts as well.
Okay. I think this question is hard, so that's why. I told you guys, some easy, some hard. Okay. Okay, I think it's enough for this question. So let's go ahead. Anyone wants to explain the question and the answer before I reveal the answer?
Yeah, so someone is writing, explaining in the chat. He's saying,
Yeah, I saw because of
yeah, you saw? Yeah.
Okay. Okay. So guys, let's just go one by one. Okay. Okay. Displaced distal radius fracture in his left forearm. Okay, this is an indicator. Upon examination, the patient exhibits weakened pronation, weakened flexion of the index and middle fingers of the distal interphalangeal joints, and weakened flexion of the interphalangeal joints of the thumb. When asked to make the OK sign, okay, clap circle, no areas of sensory loss are detected. Okay, so now we knew these things. I saw that you guys in the chat, no one chose A and B, so all of us agree that it's not going to be neither A or B because it's obviously something that's damaging the medial nerve. Okay, the median nerve, sorry. So let's cross A and B. Now we're left with C, D, and E. Okay, so guys, just focus with me. It's an important concept. If you want me to repeat it, I can repeat it. Okay, so let's just start from the most important thing that they said, which is no areas of sensory loss are detected. Okay, so the nerve that's affected is purely a motor nerve. Okay, so now we can cross which one? So now we can cross D. Okay, because they just generally said the median nerve. Okay, and the median nerve could be sensory, could be motor, even though it's okay, it's correct that it's proximal to the carpal tunnel, but however, because no sensory loss, let's cross D out. Okay, now we're left with C or E. Okay, recurrent branch of the median nerve and the anterior interosseous nerve branch of the median nerve. Now let's just talk about each the muscles and the functions that are happening for each muscle, for each nerve, sorry. So I actually don't want you to see the answer. Okay, let's see. Okay, the answer is C, but let's go on to this to explain why is it C. Okay, so here's the median nerve. Along the median nerve, we have nerve that's coming up, which is basically the anterior interosseous nerve. Okay, now anterior interosseous nerve is a purely motor nerve. Okay, it's not sensory. That's why there was no sensory loss, if you noticed in the question. Okay, so now which muscles are supplied by the anterior interosseous nerve? The first one is going to be the flexor pollicis longus. From its name, flexor pollicis longus, it's the one that's responsible for flexing the joints of the thumb. So it's not there. There would be weakening of the flexion. Okay, this is basically the first one that's seen here, where they said that we have we have weakened flexion of the interphalangeal joint of the thumb. Okay, this is the first symptom. Now, the second one is the flexor digitorum profundus. Now, before talking about this muscle, can you please, it's actually an important muscle. I want someone to tell me why it's an important muscle. Can someone tell me?
Because it's supplied by two nerves.
Exactly. Yes, you're right. Because it's supplied by the which nerves and which nerves?
Ulnar and medial.
Yes, exactly. So it's supplied by the ulnar and the median nerve. The branch of the median nerve, which is the anterior interosseous nerve, is supplying the lateral half of the flexor digitorum profundus. Okay. Now, flexor digitorum profundus is an important muscle. Now, why would it be an important muscle? Because it's actually responsible for, guys, just focus with me, okay? It's responsible for the flexion of the joints of the first and second finger. Now, as we said, flexor digitorum profundus is supplied by two, median and ulnar, okay? So let's remove the ulnar out. That's why we're gonna remove these two fingers, okay? We're left with these two fingers. These two fingers are supplied by the flexor digitorum profundus part that's supplied by the median nerve, okay? Okay, so now what is this muscle going to do to these fingers? Flexor digitorum profundus is a muscle that actually flexes the distal interphalangeal joints. So it's going to flex the distal interphalangeal joints. Normally it flexes them, okay? So now we have a loss of the nerve supply of the lateral part of the flexor digitorum profundus. So now the flexion of the distal interphalangeal joint is not going to be there, okay? That's why there will be weakening of the or loss of the flexion of the distal interphalangeal joint of the index finger and the middle finger, okay? Which is basically seen in this question, weakened flexion of the index and the middle finger at the distal interphalangeal joint, distal, okay? Because proximal are supplied by the flexor digitorum superficialis, okay? Now, two symptoms are clear now. The first one is weakening flexion of the interphalangeal joint of the thumb. The second one is weakened flexion of the index and middle fingers at the distal interphalangeal joint. The third one is weakened pronation. Now, why weakened pronation? Because the muscle that's also supplied by this nerve is going to be the pronator quadratus. Pronator quadratus is the muscle that's responsible for pronation. Damage to this muscle would result in loss of pronation or weakened pronation, actually. That's why basically it's associated with weakened pronation. Okay? That's why the correct answer is going to be C. I hope it's clear for everyone. I hope. Because guys, it's an important concept. I want you all to know it. If anyone has any question, please let me know so that I can repeat. Guys, any question? Tap in the chat, or if you want to unmute yourself to ask me any question, you can ask. Okay. It's clear. Yes, we're 45 here. I hope that all of you got it, okay? Please let me know if you did it. Okay. Let's go to the second question. So guys, please, I saw the lecture of the clinical anatomy of the upper limb. It's actually, it was so dense. It was so dense. I reviewed it. I went over it. It was so dense. So, but try to focus on the most important things. For example, when you see a nerve that's purely motor, not sensory, make sure to know that it's not related to any sensory loss. Know exactly where the nerves are going to go. For example, here we have the carpal tunnel. We have the recurrent, the median nerve continuation here. Before the carpal tunnel, we have a sensory branch here, which means that sometimes in carpal tunnel syndrome, the sensory supply is not going to be lost. So these things are so important to know, okay? Because they are actually they are guidance or helpful in the questions, okay? Now let's go ahead.
Amr,
Yes.
we got a question. Shadan's asking if you can repeat why there is no sensory loss.
Okay, sure. So basically in the question they mentioned that no area of sensory loss is detected. Why? Because I just want to clear the okay. So let's repeat. Here we have the median nerve, okay? Median nerve carries motor and carries sensory, okay? It continues. It gives us this branch. This branch is called the anterior interosseous nerve. Now, anterior interosseous nerve is a purely motor branch, okay? So it doesn't have any sensory supply. It just supplies these muscles, and it does flexion. Sorry, it does it does the function of these muscles. It's not responsible for any sensory supply. That's why in the question they specified for you that there was no sensory loss. However, if there was any sensory loss, for example, if let's say, for example, they mentioned that there was a sensory loss of the palmar area of the first two fingers. If they mentioned this, we can assume that the median nerve is actually damaged, and it's damaged from an area that's proximal to the carpal tunnel. So answer D would be correct in this situation. Just if they mentioned if there was sensory loss, okay? So if they mentioned that there was sensory loss, for example, the damage would for example be over this area, which would result in the loss of function of all of these, okay? That's why the sensory function is so important in this question. Is it clear, Shadan? Okay. The recurrent branch of the median nerve actually supplies the thenar muscles, which they are the muscles of the thumb. Okay, we're coming to these muscles now. Okay, we're gonna talk about them. So the recurrent branch of the median nerve supplies as we can see here, it supplies two main things. Wait, let me erase the ink. So it supplies the three thenar muscles. It also supplies the first two lumbricals. Okay. Remember we said third and fourth lumbrical were supplied by the ulnar. First two are supplied by the recurrent branch of the median. Okay. Also the thenar muscles. You actually revealed the question that's coming up. Okay, let's go. Let's go. Yes, a patient playing softball. I think it's an easy question. Just relax your mind and answer immediately. A patient playing softball cuts the palm of their hand as they scoop up a piece of glass along with the ball. If the only nerve damaged is the recurrent branch of the median nerve, which movement of the thumb will be lost? Okay. Okay. Okay, guys, it's D, but can you tell me why not abduction? Why not flexion? I want someone to tell me why not, please. If anyone can unmute or just type in the chat so that I make sure that you guys know exactly why.
Is it because the recurrent branch of the median nerve supplies the thenar muscles, which they are used for oppositions, so they do not flex the distal phalangeals, and flexions of distal phalangeals are being supplied by different nerves. For an example, in distal phalangeals, they're not being supplied by the recurrent branch of the median nerve. They're being supplied by the anterior antrosis of the median nerve.
Yes, you're kind of, yeah, part of your answer is correct, but there's something that's missing, which Salma answered. Thank you for answering. Actually, you're right. The recurrent branch of the median nerve supply the thenar muscles. What are the thenar muscles?
Okay, yes. We have the flexor pollicis brevis, and then we have the apponus pollicis,
Okay.
and adductor pollicis.
Okay, you're right. Okay, so you said flexor pollicis, you said abductor pollicis. We have abduction, we have flexion. Why wouldn't you choose A and C?
Because wait, hold on. I think because also we can there is another muscles that are being supplied by another muscles that are being supplied by another nerve that they can do the abduction and the flexion, so we don't lose them.
Exactly. You're correct. You're 100% correct. So because abduction, even though we have abductor pollicis brevis, however, we have abductor pollicis longus. That's basically also producing abduction. For flexion, we have flexor pollicis longus, which is also producing flexion, and it's not supplied by the recurrent branch of the median. Okay. The only muscle that's causing the only muscle that's only supplied by the recurrent branch of the median nerve is the apponus pollicis, as we said, which is responsible for opposition. Adduction is supplied by the ulnar nerve. Okay, is the responsibility of the ulnar nerve. So that's why. And also, if you guys notice in the question, they said lost, completely lost, not weakened. Okay, abduction is weakened, flexion is weakened, but they are not lost. So because they mentioned lost, it's going to be the opposition. So yes, it's opposition. I think it's a straightforward question. Let's move on. Okay. So yes, 23-year-old medical student complains of loss of sensation in the skin on the medial edge of her left hand, including the entire fifth digit. The associated motor deficit probably involves weakness in which of the following? Okay. Guys, you can write your answer in the chat, or if you want to unmute, you can unmute. It's okay. Okay. So as we said, this medical student complains of loss of sensation. Okay, they said medical students. I know all of us suffer, but however, loss of sensation in the skin on the medial edge of the left hand. Okay, including the entire fifth digit. So we have loss of sensation of this area. Okay, The associated motor deficit probably involves weakness in which of the following. So we know by now that the ulnar nerve is affected. Now, the function that's going to be damaged as a result of this damage to the ulnar nerve, it's going to be the abduction of the index finger. Why? Because this is basically tackling the hand muscles. As we all said, as I said earlier, the hand muscles are mainly supplied by the ulnar nerve. So we have the third and fourth lumbricals that we talked about. We also have the dorsal interossei and palmar interossei. Okay. Now, because of these muscles are affected, palmar interossei results in, let's see, palmar interossei. Now, this is the palmar interossei. Palmar interossei is resulting in adduction. Okay. So P and D. However, P is resulting in adduction. D is resulting in abduction. Okay. So here we have a damage to the ulnar nerve. That's why one of them is going to be they could be affected, but the answer was abduction of the index finger, which is basically the responsibility of the dorsal interosseous muscle. Okay, that's why the answer is D. Okay. Now, something important about this topic is that sometimes in the OSP or in the MCQ questions, they get us a question that's basically a medical student, blah, 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 when the doctor wanted to do a test for this patient. So the doctor, okay. So this is the heme checklist. So the doctor put a paper in between the fingers and asked the patient to close the fingers on it, and then the doctor tried to pull the paper. Okay. So what is the doctor exactly testing here? The doctor is testing adduction. Okay. So which nerve is tested by this test?
The ulnar.
Exactly. It's the ulnar, which is basically why? Because this is basically talking about adduction, testing adduction, which is the function of the palmar interossei muscles. Okay. This is a so important question actually. It usually comes in the OSP and the MCQ, okay? Or in the MCQ. So please make sure to know this concept. Now let's move on to the supply. Guys, this is an important picture. Maybe you're gonna get a direct question about it. Maybe it's just gonna be mentioned in the question, like you have a loss here in the median nerve, here in the ulnar nerve. So just go over it, okay? Now, a 74-year-old man complains of pain in his right hand and fingers when he works with his hands for a while. Thorough testing reveals insufficient blood flow into the deep palmar arch. Okay, خلاص. It's supposed that we all knew the answer. Okay. Occlusion of which of the following arteries is the most likely cause of this condition? Anyone would like to answer it? Yeah, okay. I see in the chat. Yes, it's D. So the okay. So we have two main palmar arches that are found in the hand. The first one is going to be the deep palmar arch. The main artery that's contributing to the formation of the deep palmar arch is the radial artery. Okay. Also, we do have the superficial palmar arch. The main arch that's contributing to the superficial palmar arch is going to be the ulnar artery. Okay. Guys, I know it's an easy question, it's a straightforward question, but this question sometimes you might get it in the OSP or in the MCQ because as far as I remember, Dr. Ataf used to stress on this concept. And I remember seeing actually like a picture of the hand with superficial and palmar arch, asking, pointing up to one of them, on one of the arches, and asking what's the major contributor, which artery is the major contributor to the formation of this arch. So you should know basically superficial, ulnar, deep, radial. Okay. Now, yeah, this is an important question. So guys, take your time while answering it. Okay. MashaAllah. I thought it's a hard question. MashaAllah, MashaAllah, MashaAllah. Okay. So, guys, I just want you to know I brought this question on purpose because this question we got it in our MSK midterm. The same exact question, maybe different wording, but it was asking about the same exact arterial supply. Okay, so that's why I brought this question, and when I sent it to Ghazi, he immediately knew that we got this question in our midterm because it was like we all messed up in this question. Okay, so that's why we remember. So
I'm glad they knew the answer, mashallah.
yeah, mashallah, mashallah, guys. I think mashallah you're doing great. So I just want one to unmute and explain for us the anastomosis around the scapula. Can someone volunteer? Yeah, guys, the anastomosis thing, you'll probably get questions about it. Whether it's the elbow anastomosis, whether it's the knee anastomosis, scapula, you will get questions about it. Okay, so please make sure to know it. You can get it either in the OSP or in the MCQ. Okay, because there was a discussion about this question in the you guys got the you guys got this question in the midterm. Oh, okay. Some are saying yes, some are saying no. Okay, like I'll answer it. Okay, so okay, if you got it in the midterm, I think you won't get it in the final. However, you would get something that's related to the elbow, to the knee, or to the hip. Okay, so please make sure to know all the anastomosis. Now, let's start. So, okay, to the upper lateral portion of the pectoral region, pressure applied to the wound. Okay. What do we have to know from? Okay, so the question actually starts from here. In the emergency department, vascular clamps were applied to the axillary artery, proximal and distal to the site of the injury, which had occurred between the second and the third parts. Okay. The vascular surgeon knew there was time to repair the wound of the artery because of the rich collateral pathway provided by the anastomosis between which of the following arteries. So basically, this question is tackling the anastomosis that's around the scapula. I'll just explain in this diagram. This is basically the anastomosis around the scapula. Here we have the subclavian artery. Okay. Before talking about the arteries, the block was between the second and the third, so it kind of was over this area. Okay. So the surgeon basically clamped these areas, blocked the supply to this area. However, there was continuation of the blood supply to the throughout the arteries. How? Because we have this a branch from the subclavian artery, which is the thyrocervical trunk. Thyrocervical trunk is giving us two main branches: the suprascapular and the dorsal scapular artery. Okay, or the transverse cervical artery. Suprascapular above the scapula, transverse cervical or dorsal scapular, posterior or dorsal to the scapula. Okay, so these two arteries that are forming the first part of the anastomosis. The arteries that are anastomosing with these two arteries are the branches of the subscapular artery, which they are going to be circumflex scapular and the thoracodorsal. Okay, now let's go back to our question. The question is asking which two arteries could make the anastomosis. Now, B is not, D is not, E is not. C, why they are not? Because these arteries are not even mentioned in the anastomosis of the scapula. Okay, so we have A, it has the arteries that were mentioned. We have C, which has the arteries that are mentioned. So transverse cervical and suprascapular. These two arteries are actually located next to each other. They're forming the first part of the anastomosis. So they are not the reason why there is continuation of blood supply through the circulation of these arteries. That's why we can't choose this answer. There has to be an artery from here and an artery from here. And, oh, oopsie. Okay. And that's why it's going to be actually C, the suprascapular, as well as the circumflex scapular. Okay. Because the anastomosis thing is actually an important concept. And it was one of my favorite things in MSK, to be honest with you, because I like memorizing these stuff. So make sure to know it. The elbow, the knee, the hip, as far as I remember. I'm not sure if there is anything else, but if there is, memorize it. Okay. Okay. Any questions? I assume that there will be no questions. Let's move on. Okay. So guys, here I put some of my notes. Before talking about my handwriting, I know it sucks. All of my friends tell me it sucks, but I highly encourage you to go through it. If you don't understand some things, just email me or send me a WhatsApp message. I'll explain it to you, okay? Because I'm usually not a note person. I don't like writing notes, but the only block I wrote down notes was in MSK. And some of my friends benefited from it a lot. I think Ghazi can tell you guys. So please go through them. Maybe there are some extra things. However, just go over the things that you were taught. Okay. So I included the pulses. Here you can see the pulses. All of the pulses. I included them. Their location. They are so important. Here we have the continuation of the pulses. Okay, all of the pulses. Guys, you know this when I wanted to put these notes in the slides, it took me like half an hour just to know what exactly this abbreviation meant, because I do abbreviation from my mind. It's the anatomical snuff box. I wrote it down in the notes section. Okay, if there are any abbreviations, I tried my best to write them down in the notes section. Okay.
Can I ask you a question? Do you have anastomosis? Did you write anastomosis notes in the PowerPoint?
Actually no, but if you want I can send you
Yeah,
because I saw my notes. I noticed that it's kind of messed up. I don't know how did I study it and it was messed up, so I will do another one and then send it to you guys if you want. Okay, if
you don't mind, can you do that please?
Now actually, because of shortage of time, I assume let's go to the questions, but I can draw it down later and send it to you.
Yeah,
you all guys just on the announcement batch, okay? If you don't mind.
Yeah, and on the announcement, if you don't mind.
So here we have the reflexes, which they are so important. The roots, which they are so important as well. So guys, please make sure to go through them. Okay, this is superior gluteal nerve, inferior gluteal nerve. Yeah, JTR. It's what was it? Sorry. Yeah, it was jerk tendon reflex. Okay, jerk tendon reflex. Okay. Question 10. This is the last question of the upper limb. So yes, go ahead.
G?
Just 1 second. Let them all right.
Yeah, they are all writing in the chat, D.
Okay, mashallah. Yes, guys. The answer is D. It's also a straightforward question, but it's an important concept. You guys have to make sure that you know exactly how would a patient present, why would it happen, and so on and so forth. Okay, so it usually happens in children. For example, a 2-year-old, persistent crying. Sometimes, most of the time, they're going to be crying. They can move the right arm. The episode began 2 minutes ago after the mother lifted him up by the arms. So it's basically the typical type of injury that could happen in this situation, which is when the mother holds the patient's holds the baby's or the children's arm and just pull it. Okay. Now this would result in the most common type of injury that's going to be seen, which is going to be nursemaid's elbow. Now, what's happening in nursemaid's elbow is that we have the radial head is surrounded by a ligament. Can someone tell me what's okay? Let's hear. So it's the annular ligament. So the head of the radius basically it's inserted into the annular ligament. Annular ligament surrounds the head of the radius. Okay. So whenever someone pulls the radius, it's going to be like pulled away from the annular ligament, which would result in the typical type of injury, which is nursemaid's elbow. Okay. Any questions? This question was also from the clinical anatomy of the upper limb. Guys, for the clinical anatomy of the upper limb, I know it's too much, it's too dense, but try to study it like study it wisely. Okay, don't try to memorize every single thing over there. Try to understand sometimes. Although MSK is about memorization, I know, but however, you have to understand sometimes why there is motor, why there is sensory, and so on and so forth. Okay, go over the slides. Make sure to know the most important thing and the things that Dr. Atif stressed on, because usually he gets things that he stressed on. Sometimes he doesn't, but they're not that hard questions. And focus on the most important things, because it has few things that okay, yani if you see them, you can make sure that they are not coming. Okay, if they come, it's your luck. So I don't know what to do. So okay. Good luck with it, to be honest. Any questions about the previous questions in the upper limb? All good? I just want you guys to make sure that you understood this question. If you understood this question, خلاص, we can move on. Yes. Sure, I can repeat the scapular anastomosis. Okay, so where was the scapula? Okay, so basically, let's erase the ink. So we have there was basically a damage to the axillary artery. The surgeon wanted to clamp the artery. Okay, so the surgeon clamped the artery from this side and from this side. So here there will be no blood supply. So what's gonna happen in this situation? We have some anastomosis. These anastomosis that are arising from the first part, which is going to be the subclavian artery. Subclavian artery has this thoracocervical trunk that's arising from it, which is giving branches, which they are the suprascapular artery and the dorsoscapular artery. Okay, so these two arteries are coming from here. Now, if we assume that we clamp the artery from here, it's obviously we won't have blood supply in this area, right? However, we can still see that there is blood supply. Why is this happening? Because this area has branches, has arteries, which they are over there. It has an artery called the subscapular artery. This subscapular artery is giving rise to two main arteries, which they are the circumflex scapular and the thoracodorsal. These arteries are basically anastomosing with these two arteries, this one and this one. That's why there will be blood supply to this area, even though we clamp this area. Okay, is it clear? Yes, clear. Also the slide. Yes, sure. Oh no, it's yes, sure. This one. Shadan, is it this one? Okay. Do you have any questions or?
Guys, we are going to send you the slides, inshallah, after
Yeah,
the
yeah,
lunch.
you're gonna have them. Okay.
Yeah, after the session, inshallah, right after the session, I will talk to your VLC to send you the slides on the announcements group.
Let's go ahead and start with the discussion. MashaAllah. Okay, guys, you're all are answering B. Can someone unmute and tell me why?
Okay, because first thing first, the cruciate ligaments are used to prevent the tibia and the fibula from sliding either posteriorly or anteriorly. We are checking the posterior cruciate ligaments because we are checking if it's going back posteriorly. That's what he's doing. That's why.
Exactly. So basically, you're correct. Thank you so much. The first thing in the question is examination revealed posterior displacement of the tibia upon the femur. Okay, so the tibia is going posteriorly. Physical examination showed a positive posterior drawer test. I think khalas. We knew this. We knew this. We're gonna know the answer immediately. So the answer is going to be B, posterior cruciate ligament. Let's see why. Guys, this is important thing. You should make sure to know it. The first one is going to be the posterior cruciate ligament, and the second thing is the anterior cruciate ligament. Let's start with the posterior cruciate ligament. The posterior cruciate ligament is basically attached in the posterior part of the tibia, as well as the anterior part of the femur. Okay, so because it's attached at the posterior part of the tibia, it's going to prevent the tibia from going posteriorly. Okay. At the same time, because it's attached anteriorly, it prevents the femur from going anteriorly. Okay, these two things you have to make sure to know them. Okay, now the second thing is that this ligament becomes stretched and condensed, like stretched. In which situation? When the knee is flexed. Okay, so we can see when the knee is flexed, this basically ligament is going to be stretched, which means that it's more prone to injuries. So in a flexion situation, when we are flexing our knees, we have a higher chance of having posterior cruciate ligament if we like have any hit or any damage. Okay, this is basically what's happening in the posterior cruciate ligament. Now, when would you see these type of injuries? You would see this type of injuries, for example, if you're يعني لا سمح الله, you could have any car accident or whatever. A dashboard injury would cause the force here, which would result in basically sorry, not here. It would result in force that's coming up in this area, which would result basically in the tibia to be displaced posteriorly. Because also in the car you will be sitting, flexing your knees, so it's basically a higher chance of having a posterior cruciate ligament tear. Okay. Also, you can have them when there is a slide that's mentioning all of these. Don't worry about it. When you're basically on the motorcycle and you fall down, and this would be damaged. Okay. However, posterior cruciate ligament is not as common as anterior cruciate ligament. Okay. Now let's go to talk about the anterior cruciate ligament. Anterior cruciate ligament attaches to the tibia anteriorly, which means that it prevents the tibia from going anteriorly. At the same time, it prevents the femur from going posteriorly because it's attached posteriorly. Okay. So this is one thing. The second thing is that this ligament is basically stretched in an extension situation. So this tells us that when do you think that we can see injuries for this cruciate ligament, anterior cruciate ligament? In which type of injuries?
Sports.
Yes, exactly. Sports injuries, which is basically we can call it ACL tear. Okay, because in sports, while you're playing or doing whatever, you're basically extending your knee, which means that if you have any injury or any injury, the ligament is going to be stretched, which means that it's going to be most likely affected. Okay. Now this is a table I did, guys, for you. So attachments, it has taut and injured. Just this part means that it's basically taut or stretched when the joint is extended, and that's why basically associated with higher chance of injury. Okay, what does it prevent and what are the most common injuries? memorize this table because it's so important, okay? Let's go to question 12.
So yeah, they are saying A.
A and E. Okay. So the correct answer is going to be A. Why would it be A, not E? I think we all agree that we can cross B, D, and C. Why? We're going to talk now. So a football player was tackled from the lateral side of his knee, just as he put that foot on the ground. Okay. Unable to walk without assistance, he is taken to the hospital. An MRI examination reveals a torn medial collateral ligament. Okay. Which now, up to this part, we can say that it could be A and it could be E, up to this part. Now, once we start this part, which structure would most likely also be injured due to its attachment to this ligament? Okay? Whenever we see this sentence, it's obviously not going to be E. However, E could be damaged, but they are saying that the structure that's attached to this ligament, which is basically the medial meniscus. The reason I brought this question, and also we can eliminate these because they're not commonly seen in this type of injury, okay? Now, the reason I brought this question is that it's an important thing to know that the medial, the medial collateral ligament is firmly or directly attached to the medial meniscus, okay? At this area, you can see here, it's basically directly attached to it. However, on the other side, the lateral collateral is not directly attached, okay? That's why whenever we have a medial collateral ligament damage, it would also result in damaging the medial meniscus, okay? Like a package, okay? Any questions? For the people that chose E, I hope it's clear now. You're actually right. Anterior cruciate ligament could be affected, but the question is asking about which structure would most likely be injured due to its attachment to this ligament. That's why we chose A. Okay? So that's why make sure to read the question and to highlight the most important things. Oh, I repeated something. Okay? Let's move on to our next concept. Okay. So anyone knows what concept are we going to talk about?
Unhappy triad.
Yes, and the unhappy triad. Okay, so the unhappy triad. Okay, forget about this. This is a mnemonic that I did. We're gonna talk about it. So the unhappy triad is an injury that happens most commonly in two situations. Okay, the first situation is when someone is skiing and they hit like something like this. Okay, once they hit it, because the foot is stabilized on the ground, there would be a damage like into, how I'm going to say it, like into this area, okay? This area of the knee. The damage is going to be most likely targeting the medial part, okay? Which would result in the medial collateral ligament damage. What's the package that's accompanying the medial collateral ligament? What is it? That always would happen with the medial collateral ligament tear?
Meniscus.
The medial meniscus. So that's why we have medial collateral ligament damage as well as the medial meniscus. And as we said, because in these types of injuries, the leg is going to be extended. That's why also the anterior cruciate ligament is going to be affected. Now let's talk about this this mnemonic. This mnemonic is mom. It means like someone is injured or screaming, telling and saying mom and so on. Okay, so just M, A, and M. M, A, sorry, M, A, and M. Okay. All clear about the unhappy triad?
Yes.
Okay. Okay, let's go ahead. So in the question, expect to see, like, for example, someone is skiing and they hit this. Another scenario that could also have unhappy triad is scenario that's like this. When someone is going to when someone is playing, for example, football, and other one is going to tackle the person. Once they tackled from the lateral area, which is this one, they're going to push the knee to this area, which would result in tearing on the medial collateral and the medial meniscus. This is another scenario that could happen. Also, okay. Now let's talk about the question 13.
A?
Let's just wait to the others. Okay. Yes, correctly. It's A. So a female house cleaning. So the keyword here is basically the house cleaning business. Okay. So this is the most important keyword that you have to make sure to understand why. Okay. This is the outpatient clinic with a complaint of a constant burning pain in her knees. Okay. Which of the following structures is most likely affected? Now, basically from the scenario, a house cleaning business, sometimes it's, I don't know why, but it's associated with someone that's basically, for example, if someone wants to clean something, they're going to be sitting on their knees. So because of this, the most commonly thing that's going to be affected is going to be the prepatellar bursa. Even though infrapatellar bursa could be affected as well, but the most common one that's going to be affected is the prepatellar bursa. Okay, so whenever you see house cleaning business, just immediately go for prepatellar bursa. Okay, of course, continue reading the question, but choose prepatellar bursa if you're 100% sure about it. Okay, so here is the slide. Here we have the prepatellar bursa. House cleaning means that they're sitting on their knees, so they're sitting on this area, which would result in its basically inflammation, and it would result in what's called bursitis. Okay. Another important concept is the popliteal Baker's cyst. How questions are going to come about the popliteal cyst is that, for example, a patient is feeling a lump or an enlargement in the popliteal fossa. This enlargement is actually limiting the flexion. Okay, limiting the flexion at the knee. What would be the cause? It's going to be most commonly popliteal or Baker's cyst. Okay. The third thing I want you to know from this slide is the preferred side of joint injections. For example, if they say that a patient that's coming with a joint pain, they're suspecting an inflammation or whatever, they want to draw or aspirate fluid. What would they do is that they would go all the way into the preferred side of the injection or aspiration, which is the suprapatellar bursa, and then they are going to draw fluid from it. Okay, these three things: bursitis, popliteal cyst, and suprapatellar bursa. Okay. I hope it's clear. Let's move on to question 14. So during an interview, a 30-year-old man who's a psychiatric patient suddenly becomes aggressive. In order to calm him down, the patient is given an intramuscular injection in the upper lateral quadrant of the buttock. The injection is given at this specific location to prevent damage to which of the following nerves? Guys, mashallah, you're answering immediately. Okay. Anyone wants to explain why? Okay, I can go ahead. So it's just asking about the preferred site of injection. Which one would we prefer to inject an intramuscular injection in? Okay. We got this question in our exam, which was asking us about the preferred site of injection. Basically, we can divide it into 4 quadrants: the upper lateral, upper medial, lower medial, lower lateral. Okay. Now, because of the relationship with the nerves, and the most important one is going to be the sciatic nerve. Okay. So the sciatic nerve is the most commonly nerve that could be damaged in case of intramuscular injections. That's why we try to give the intramuscular injection in the upper lateral quadrant to avoid any damage to this nerve. Okay. However, sometimes in the questions you might see superior gluteal nerve. I saw some questions that had in the answers the same question, the same wording, asking about the same thing, and which of the injection is given at this specific location to prevent damage to which of the following nerves. The superior gluteal was one of the answers. Okay, but most of them are saying that you will go with, even though superior gluteal nerve is mentioned here, but you should go with the sciatic nerve because it's most commonly injured, and that's why. Okay, it do be like that sometimes. So let's go with the sciatic always. Tamam? Or sciatic. Any questions? We can move on. So question 13. This is a question that we also got in an exam. It's either us or the batch before. But I remember seeing the picture. MashaAllah. Yes. It's the okay. So a young man suffers a dislocation of the right hip in a car accident. During recovery, he finds he has an abnormal gait in which his left hip sinks when he lifts that foot to take a step. As shown in the right frame of the given diagram, the problem may be a result of damage to which of the following structures. So they said that frame C. So let's take a look at C. What can we see here is that we have like this part is going downwards. Can you guys tell me what's basically the name of this sign?
Trendelenburg sign.
Yes.
Positive.
Yes, exactly. So I think you should know how to write it, because sometimes they get an SEQ about this whole scenario, because it's actually, why would they get it? Because it has an association with dislocation of the right hip. Okay, so they might bring an SAQ that's asking about dislocation of the right hip. Then they bring you a question like this, having a picture telling you what's the name of this sign and why would it happen. Now, something that's tricky in this sign is that even though you see that this part is going downwards, however, it's not the damaged part. Which part is down? If the left is going downwards, which part is damaged?
It's the other
Right.
side.
It's the other side. Okay.
Yeah.
So whenever we see this, we know that the damage is on the right side, so we can cross out B and C. Okay. Now let's go ahead with A. The right gluteus maximus. Gluteus maximus has an important function, which is the extension of the hip. Okay. So it's not basically associated with the with stabilization. So that's why we can cross it out, because its major function is extension. We're left with D and E. Now, can someone tell me why you guys chose D? Can someone tell me why you didn't choose E?
Because E, inferior gluteal nerve, supplies the gluteus maximus. Meanwhile, D, it's the right, because right gluteus medius is being supplied by the superior gluteal nerve.
Yes, you're correct. So even though both the right gluteus medius and the gluteus minimus are responsible for the stabilization, and if they are affected, Trendelenburg sign could happen. However, if you continue the answer, and inferior gluteal nerve, it's not the inferior gluteal nerve. These muscles are supplied by the superior gluteal nerve, which is why the answer is going to be D. Okay?
Can I ask you just one more small question?
Yes, sure.
If, for example, the gluteus medius gets affected, does the gluteus maximus medius minimus also, does it also get affected because they're like from the same nerve, get supplied by the same nerve?
It actually depends. It depends on a lot of things. One of them could be where exactly is the damage to the inferior gluteal nerve, because if it's before when it divides to supply the medius or the minimus, or after it divides. So it could be both of them. It could be one of them. Okay, but I think most of the time, if you see like this nerve is damaged, both of them are going to be damaged, or just if any one of them is damaged, the whole function is going to be affected, okay, or weakened. Okay, Did you get my question?
Yeah.
Sure.
Sure.
One more thing I would like to address here is that the right gluteus maximus. Now, right gluteus maximus, we said that what's the function of the right gluteus maximus?
It's the extensor against.
Yes. Okay. So it's basically an extensor. So let's imagine, let's say that we get a scenario. An elderly, for example, 70-year-old male was not able to stand from a sitting position, or was feeling like weakness while going up the stairs. Okay. Now, which muscle would be affected? It would be the gluteus maximus, especially if the scenario, for example, was asking about if someone is in sitting position and want to stand up, okay, which is basically the extension of the hip. That's why gluteus maximus will be affected. Okay, so you could actually get a question about this, and which nerve is supplies it. For example, it's going to be the inferior gluteal nerve, and so on. So just expect these types of questions. Okay. All clear?
Yeah.
Okay. Yes, let's go ahead. Question 16. It's a straightforward question, but it's an important thing to know. That's why I wrote it. So, okay. Okay. Yes, you're right, guys. So basically, when we want to use something for surgical grafts or reconstruction or whatever, the muscle that's going to be used is going to be the gracilis muscle. Okay. Why? I looked it up. Most of the resources are saying because it's actually not useless. We can't say it's useless, but it has the lowest function. So it's not that important. So if it's basically lost or basically being used for other things, it's okay. Okay. And also basically they're saying that a weak adductor of the leg, so that's why we can say it's also gracilis. But the muscle that's going to be used for surgical grafts or harvested to reconstruction is going to be the gracilis. Other things, actually, I didn't get a question about, which is basically the great saphenous vein. I wrote it down in the notes section. I'll send you the slide so you can see it in the notes section. It's basically the great saphenous vein. Great saphenous vein is a vein that could also be used in other surgeries. For example, in cardiac bypass surgery, which is basically when they want to bypass the blood from an artery to another artery, they put like a link. This link is going to be taken from the great saphenous vein. Okay. So this is an important thing to also note down. Now let's talk about question 17. It's also a straightforward question, but it's an important topic to be to know, because Dr. Atif likes these type of questions, like when there is a muscle that's basically having something significant, such as the flexor digitorum profundus, such as the adductor magnus. It's so important. Oh, I said the answer. Sorry, guys. The answer is, yeah. The answer is A. Why is the answer A? The adductor magnus basically has two main parts. The first part, which is the lateral part, is supplied by the tibial artery, and the medial part, which is basically with the adductor, which is responsible for adduction, it's supplied by the obturator nerve. Okay, that's why basically it's A. Now, this is basically the adductor magnus. It's supplied by the obturator nerve, the adductor, the medial portion, the lateral portion by the tibial nerve. Now, important thing to note in this slide is this: the adductor hiatus, or we can say it's basically the adductor canal. Why is it important? Because important structures are going to pass through it. The first one is going to the femoral artery. Femoral artery pass through it to become the popliteal artery, and the femoral vein, the popliteal vein, it actually exits from this to become the femoral vein. Okay, it's important to note this this thing as well. Now, a 34-year-old man is lifting heavy weights while doing squats. Unfortunately, while making a maximum effort, he drops the weight and immediately grabs at his upper thigh, writhing in pain. The man is admitted to the emergency department and during physical examination is diagnosed with a femoral hernia. What reference structure would be found immediately lateral to the herniated structures? Okay, I thought that it's kind of like a hard question. MashaAllah. Okay. So the answer is A. Anyone would like to tell us why the answer is A?
We use the mnemonic navel from lateral to medial, and so there's like an empty space for E, and right before that there's the femoral vein. So that's why.
Exactly. Yeah. Even though we have femoral artery that's lateral, nerve that's lateral, but the most lateral thing that's immediately lateral to the empty space, which is the space where most inguinal hernias are going to be, it's basically the femoral vein. Okay, let's see why. So here we have the femoral triangle. The femoral triangle, basically, guys, make sure to know the borders of the femoral triangle because they ask about it either in OSPE or in the MCQs. So the superior is going to be the inguinal ligament. The lateral is going to be the sartorius muscle. The medial is going to be the adductor longus, and other one is going to be in the floor, which is basically the iliopsoas muscle. Okay, this is the femoral triangle. Now let's talk about the structures that are found inside the femoral triangle. Now, as you mentioned, we have a mnemonic that's navel. And another one that I use is basically the same, but to remember it, other than navel, if I'm going from outside to inside, I don't know what's inside, so I need a navigation or a navigator or whatever. That's why basically it's nav, nerve, artery, vein. On the other hand, when I'm going basically from inside to outside, I already know the how, and I'm using my van to go outside, which is basically vein, artery, and nerve. Okay. That's the one that I use. We have nerve, artery, vein. After the vein, we have the E, which is basically the empty slot. This is the empty slot where most of the hernias are going to be. And then we have basically a lymph node over here. Okay. So what can we know is that the inguinal hernia, whenever we have inguinal hernia, is going to be basically found in this area. And the structure that's going to be immediately lateral to it is going to be the femoral vein. Okay, guys. Another thing it's important to note down from this picture is basically the femoral artery. The femoral artery, why? Because sometimes they're going to be to ask about the femoral pulse. Where would you find the femoral pulse? You would say that you would find it in the femoral triangle in the midpoint between the anterior superior iliac spine and the pubic tubercle. We have the femoral artery where you can feel the femoral pulse. Okay? Lateral to it, we have the nerve. Medial to it, we have the vein. Clear? It's way harder than navel because yeah, for example, if you go to the second van, is easier for me to remember that it's medial to lateral. Yeah, because later on you will forget the navel. What does navel mean? So that's why navigator, you don't know how to enter, so you need the navigation. So that's why it's nav. And then van, خلاص, you use your own van to go outside. So that's it. What's okay, so what's the difference between femoral canal and femoral ring? Okay, so as far as I remember, that the femoral canal is basically this area which is surrounded by the femoral sheath. This could be considered as the femoral canal. Okay, when we talk about the femoral ring, I don't have a clear picture here, but let's imagine that here we have the inguinal ligament. Okay, this inguinal ligament is going to turn out like this. Okay, turn out like this. So this part here is going to be called as the femoral ring. Okay. So the femoral canal is going to be like in this area, which is basically allowing the hernia to be over here. Okay, perfect. Let's go. Yeah, guys, we're almost done. we just have a few questions left. So yeah, this is also an important question. Please make sure to read it till the end to answer the question. Okay. MashaAllah, I see a lot of C's. Yes. C. Yes, the correct answer is C. So why would it be correct answer? So in this question, we have to know two main things. The first thing is that they said that an 80-year-old, okay, for examination with a complaint of a great pain in her right lower limb, physical examination, right lower limb is laterally rotated, shorter than her left limb, and there is an intracapsular fracture of the femoral neck. So this question, yeah, from this question, the doctor can bring like 3 other questions, okay? Just from this scenario. So we have to make sure that we understand every single thing in this scenario. Why would it be C? Which of the following arteries supplies the head of the femur in early childhood, but no longer in a patient of this age? Why? Because let's see. So okay, so first let's talk about the presentation. The presentation, the right lower limb is laterally rotated, shorter than the left limb. This is basically a typical presentation of the neck of the fracture of the femur, okay, of the head of the femur. This is basically typical presentation. The patient is going to present with a limb that's shorter, as well as basically laterally rotated, okay? Shorter, why? Because if you remember from the first few questions, we said that whenever we have fracture, the muscles that are attached are going to be pulling it upwards. So the muscles that are actually attached to the femur are so strong, so that they're going to be able to pull it upward, okay? Other thing is going to be laterally rotated because of the action of the gluteus maximus and other rotator muscles. They're going to rotate it laterally, which would result in this presentation. Also, it could be associated with some abduction. This is basically a typical presentation. You should know when someone is presenting with the fracture of the head of the femur, okay? Now, moving on to talk about the important concept, which is basically the blood supply of the femoral head and neck. Let's start with talking about the first thing, which is basically the profunda femoris artery. Profunda femoris artery is a branch of the femoral artery, okay? It's one of the most important branches of the femoral artery. From this branch, we have 2 main arteries that are basically arising. The first one is the medial circumflex, and the second one is going to be the lateral circumflex. They are basically rounding around the neck, doing anastomosing with each other, okay? From them, we have the ascending cervical branches that are arising. Why? To supply the area of the head. Now, important thing to note down, 2 main situations. If we have a child or if we have an elderly or adult, okay? In children, we have an important advantage, which is basically the foveolar artery or the acetabular branch of the obturator artery. Now, the obturator artery is a branch of what's called the internal iliac. What's internal iliac? Just this information is found in other blocks, but just for you to understand why, okay? We have the abdominal aorta that's coming down. Abdominal aorta bifurcates into two common iliacs, okay? You don't have to know this. Then the common iliac bifurcates into external iliac and the internal iliac. Internal and external. Okay? The external iliac continues through the femoral and under the inguinal ligament to become the femoral artery. Okay? The internal iliac goes somewhere else. A branch from the internal iliac is called the obturator artery. Okay? This obturator artery is giving rise to the foveolar artery. Now, foveolar artery runs through the ligament of the head and going all the way to supply the femoral head. In who? In elderly or in adults, elderly or children's?
Children.
Children, okay. So it's an important thing to note down. Why? Because if we have an intracapsular fracture, the head is going to be separated than the neck, right? Right. So would in an intracapsular fracture of the head of the femur of a kid or a children, would there be necrosis or loss of blood supply to the femoral head?
No.
No. Why? Because the fibular artery is there, which is supplied, which is a branch of the obturator supplied by the internal iliac. Okay. However, in elderlies, this is not going to be there, so it basically kind of disappears or not functioning anymore. So the femoral head is going to be supplied by these ascending cervical branches. Okay. So if we have an intracapsular fracture of the neck of the head of the femur in let's say 50-year-old male, would there be ischemia or loss of blood supply to the femoral head or no?
Yes.
Yes. Okay. Yes. Because the main supply now in the for the femoral head in an elderly or in an adult is going to be the ascending cervical. So any damage would result in basically its necrosis. Is it clear? I hope so. Okay.
Yeah.
Okay. So basically the question. Let's go back to the question. As we said, laterally rotated, shorter than her left limb. Intracapsular fracture was there. Which of the following artery supplies the head of the femur in early childhood, but not no longer in a patient of this age? This artery is going to be a branch of the obturator, which is called the foveal artery. Anyone has any question? Let's go ahead. Okay, great. Guys, this is an important question. Please make sure to read it good and answer it, please. Okay. MashaAllah. Okay. Can someone tell me why would the answer be A? If it's A.
Is it the sural nerve that comes from common fibula that supplies the cutaneous part of the lateral foot and posterolateral leg?
Yeah. It could be part of the answer, but it's like there are other things.
I think that it is A, partially, I'm not sure, but I'm pretty sure it's A because common fibular splits into superficial and deep, and the deep is what provides sensory, I believe, or no, motor, and then superficial provides sensory for those areas. And since there's paresthesia and sensory loss, that means both are damaged, which means it's common fibular.
Yes, actually you're 100% right. It's the common fibular. Why would it be the common fibular? Because let's go back to the question. Immobilized in a cast that extended from just below the knee to the foot. At the time of injury, there was severe pain but normal strength in the extremity. When the cast was removed, physical examination showed a pronounced left foot drop. So we have left foot drop, paresthesia, and sensory loss over the dorsum of the left foot and the lateral leg. Okay, so they mentioned foot drop, loss of the dorsum of the left foot and the lateral leg. Now let's see why would it be A, not B or C. Okay. Here we have the common fibular or common peroneal nerve. Now, common peroneal nerve is going to divide into two main nerves, which are going to be the deep peroneal and the superficial peroneal nerve. Okay? Okay. Now, let's start with the deep peroneal nerve. Deep peroneal nerve is going to give supply to tibialis anterior, extensor digitorum longus, and extensor hallucis longus. These three muscles are basically the muscles that are responsible for dorsiflexion. Okay? Dorsiflexion is when you lift your foot upwards. Okay? So when we don't have these muscles, what's going to happen to the foot?
Foot drop.
Foot drop, yes, exactly. So there will be foot drop. Okay. Another thing from this nerve, which is so important, is basically the continuation of this nerve. This nerve is going to go all the way into the area that's going to be between the this area, and it's going to give sensory supply to this area. Okay. So sometimes when they want to test the deep peroneal nerve is functioning or no, they basically just do a test, sensation test to this area, so that they can know if it's functioning or no. Okay. So they say these are two things. This is why we have foot drop, and this is why we have sensory loss over the dorsum of the left foot. By now, we can tell that the answer could be C. Okay. However, it's A. Why? Because we have also sensory loss of the lateral leg. Now, another nerve that's coming from the common fibula is going to be the superficial peroneal nerve. Superficial peroneal nerve is supplying two main muscles, the peroneus longus, the peroneus brevis, or fibularis longus, fibularis brevis. These two muscles are responsible for the, they are everters, so they are responsible for the eversion. Okay? Yes, they're responsible for the eversion. Now, this also could give supply to the area of the lateral part of the leg, which would result in basically sensory loss over the left leg as well. So we have superficial is damaged and deep is damaged. That's why most likely the injury is basically in the common fibula, which is the main stem. Another situation would be where would you get common fibular injury is going to be when you have an accident. I remember we got a question. The person was standing, and then like a car hit the area of the common fibular nerve and resulted in fracture. This fracture caused foot drop and paresthesia. So this is another situation where you could get this question in. Okay. Now let's move on. And it's obviously not going to be neither D or E, because they said that the cast is below the knee. Okay. So let's go to this straightforward question. And a quick answer.
Is it C?
Mm-hmm. It's lagging a bit. Yes, exactly. So the answer is C. Why? It's simply because they are asking about the Achilles tendon jerk reflex. It is weakened. So what are the nerve roots that are basically going to give rise to the jerk tendon reflex in the Achilles tendon? These are going to be most likely L5S1. Although the others could be mentioned in the when we test the Achilles tendon, but the most important thing to note is basically S1. So that's why basically we can choose the L5S1. Okay. I saw some questions where they put S1 and S2. However, the answer would most of the time be L5 and S1. Okay. So this is with regards to the Achilles tendon reflex. Again, please make sure to go through all of the jerk tendon reflexes that you were taught. Okay. Please. Either it's upper or lower lung. Okay. Now let's go ahead and do question 22. Guys, if someone gets this question wrong, I'll go to liaison. I swear I'm gonna tell him. So please make sure not to get it wrong. Basically, Yazan, because yesterday he did a past session about the ankle, and he told me that he explained this concept. So I had a question about it because it's important. Also, my friend told me that he had a question about it in his exam, which is why I brought this question. Okay, so the answer is D. So basically, the question is simply asking about the posterior tibial artery. Where would we feel the pulse? The pulse is felt in the area that's going to be between the medial malleolus as well as the calcaneus. Okay. Now it's basically in the groove, so we can say that it's posterior to the medial malleolus, in the groove between the medial malleolus and the calcaneus. Okay. So it's kind of going to be like here. Here we have the tarsal tunnel. Throughout the tarsal tunnel, we can have this artery, which is going to be the tibial artery, which is number 4. Yeah, it's number 4. So the tibial artery, the posterior tibial artery is going to be number 4. This is the medial side of the foot, in between the calcaneus and the and in the groove of the calcaneus and the posterior. Sorry, in the groove between the medial malleolus and the calcaneus. Okay. It's simply asking about where would you feel the pulse. Also, another important pulse you could be asked on is the dorsalis pedis, as far as I remember. Yeah, dorsalis pedis pulse. It's so important. It tests actually the integrity of the whole arterial supply of the leg and the thigh. Okay. Yeah, question. Yeah, we're coming to the end. The last question. This is also an important question. It was taught by Yazan yesterday, and he also told me that to tell him if someone gets it wrong. So make sure to understand it well and answer it well. Oops.
They are answering Yazan's questions well, mashallah.
Okay.
So it seems that he did well yesterday. Yeah.
Mashallah. Mashallah. Okay, so the answer is correct. It's basically C, the anterior talofibular ligament. Why? It's basically the most common type of injury that's going to be seen. For example, it could be seen in sports, as well as a typical scenario could have like a female that is wearing a high heels, and suddenly she slips out, and for example, her ankle is sprained. So the most common fracture that is going to be seen as a result of the severe inversion is going to, sorry, not fracture, strain or tear is going to be due to tear of the anterior talofibular ligament, which is basically happening as a result of the severe hyperinversion or severe inversion. And it's like the most common type of injury that could be seen in hyperinversion. So whenever you have hyperinversion, immediately go to anterior talofibular, okay? So this is basically hyperinversion of the leg. What's going to happen? The anterior talofibula is going to be torn, which is the correct answer. Okay. Another thing I saw in the lectures was the POTS fracture. Can someone tell me what's the ligament that's injured in the POTS fracture?
Anterior.
Deltoid.
Yeah, deltoid.
Collectively is going to be the deltoid ligament. Okay. So, mashallah, you guys are doing great. 1, 2, 3. Okay. So, this was the whole session. I actually thought that we will do it faster than this, but we took 2 hours. I'm so sorry I took from your time 2 hours, even though you have an exam on Sunday. I hope that these questions were so helpful for you. I actually tried my best to get questions that are high yield and most likely to be tested in the exam. Okay. Yes, because we're coming to an end. Only 2 days left, guys. It's only Saturday, and then the exam is on Sunday. Okay. One thing I noted, which is basically what was it? Yeah, the OSPI. The OSPI and the MCQs and the SCQs are at the same day, guys. Our exam, when we were first years, we had our OSPI on Exemplify, okay? You guys are having it on campus in the lab. So they're both are going to be in the same day. MCQ has a lot of, MSK has a lot of MCQs and SAQs, so you have to sleep well. You have to sleep well, no matter what happens, okay? even though you're not caught up, even though you might have some lectures to review or you want to do questions, please sleep well. Because it's a long day, it's a hectic day. You have OSPE, you have lab, you have MCQ, you have SQ, you have whatever. Please sleep well, okay? Is there a break between the MCQ? Actually, I don't know because we didn't have it. We didn't have the OSPE separated. But I remember from last year's batch, yeah, they like had an hour or an hour break. Guys, here is my email. If anyone wants to be if anyone want to contact me, here is my number if you want to contact me through WhatsApp. If you have any questions about the previous slides, if you have any other questions about the exam, feel free to ask me whatever you want. Okay? How many SQs? Actually, I don't know. You have to answer the you have to ask the doctors, but the doctors won't say, I think. But yeah, guys, for the SAQ, just 1 second because I wanted to emphasize on one thing. Please stay in the meeting. I'm gonna sorry, what I'm gonna do? I'm gonna stop share. Just 1 second, okay? I wanted to so this there was an important SAQ. We had that in our exam. I got a lot of questions about why would the answer be this. I just want to tell you about it. Okay, so please wait. Okay. Sorry, guys, 1 second. Okay. What did I do? How can I share? Oops, guys. Can you see my screen?
Yes.
Yeah.
You can see the question, right?
No, we can't.
Nope.
Oops.
We can
Okay,
see the
just 1
file
second.
explorer.
1 second. Now,
Yes.
okay, you can see the question, right?
Yeah.
Okay, so guys, basically the clinical scenario was like this. It was talking about the hand muscles mainly. The question that I got is why would the muscle that's affected is the dorsal interossei, not the palmar interossei? Because some people said the hand is abducted, so the answer would be palmar interossei. However, the picture that was in our exam, it was asking about this. So they put this image in our exam, this picture in our exam, and they asked about which muscle could be damaged in this area. Okay, so the only muscle that's supplied by the ulnar nerve that could be damaged in this area would be the dorsal interosseous, which is this one. Okay, that's why the answer is dorsal interosseous. Okay. Did you get it now?
Would that be the same as the question about making the OK sign?
No, we didn't get the OK sign. We didn't get an OK sign. We got this. It was asking about the hand. A patient that had an ulnar nerve damage and which muscle could be affected. It was the dorsal interosseous because they put the picture like this. So the muscle that's going to be on this side is the one that's going to be affected. Okay.
Okay.
Which is the dorsal interosseous. So I just wanted you guys to know this because a lot of people told me about it. And also, he hasn't told me to address this question. Let's go back to the slide share. Okay. So, yes, guys, I wanted to, basically, this is a thing that me and my friends, we have a group. We usually, before the night before the exam, we send to each other these dua. So please make sure to read them, whether in Arabic or English. Just make sure to read them. If you want to take them from the slide, read them the night before the exam and in the morning before you go and before you enter the exam hall. Okay. And yeah, good luck. Wish you all the best. Inshallah, you guys really do amazing in the exam. Okay? Ya Rab, inshallah.
Thank you.
Anyone has any question, want to ask me anything, I am free. If you want, guys, anyone wants to leave, by the way, someone is saying, can you send resources for the for solve physiology? Yeah, I can send you resources. I send you resources, I send them so that they can send it on the batch group. Last minute advices for MSK. Okay, guys, just know one thing about MSK. MSK, you have a lot of questions, okay? So they will be, and a lot of slides, a lot of concepts that you have. Most likely they're going to test you on the high yield stuff, especially for anatomy. You will have some questions that are coming from the corners, but what would you do? Just focus on the high yield stuff. Make sure to review them quickly, because tomorrow is the last day. Just make sure to go over the lab material, because sometimes it's basically you guys are new for the OSPE in the lab. So make sure to know how to answer quickly and so on. This is for OSPE. For SAQ, guys, SAQ actually is the thing that unfortunately sucks in our exam. A lot of us struggle in SAQ. Why? Because we might think that we actually wrote down the answer correct. However, at the end we'll have like an SAQ. We won't get the mark that we were expecting, because sometimes they are trying to focus on some keywords in the question, okay, in the answers. For example, would we have an example? Yeah, if they let's take just a simple example. If they ask you what's the function of the brachialis muscle, if you say flexion, you will get the answer. You have to say, for example, flexion at the elbow joint. Okay, this is a simple question about this is a simple example. So make sure to write the exact answer that they want. Even though you may write more, it won't be enough for them. You have to write these keywords. You have to include them. Okay, but just make sure about this thing about the SAQ. For the SAQ, please make sure to read the question from the end till from the beginning till the end, because I got a whole SAQ wrong because I read the first 4 lines. I just skipped the fifth one. Because I skipped the fifth, the name of the disease was written in the fifth. I didn't read it. I answered 4 SAQ questions based on what I understood, which was wrong, and I got it all wrong. Okay, so please make sure to read it from the beginning till the end. Well, don't worry about SAQ. Even though if you don't do well in the SAQ, if you do well in the MCQs, at the end your grade will be good. For me, to be honest, SAQ, I got maybe the worst SAQ I've done in first year was in MSK. Why? Because of me. I didn't read the questions. The questions were easy, but I didn't read them, صراحة. So that's why but overall grade of MSK was so good. Why? Because of the MCQs. So make sure to do well in the MCQs. Okay. Anything else?